Good evening, everyone. In today's
Good evening, sir.
class, we have a case presentation here by Dr. Sumit. Dr. Sumit, over to you.
Right. Good evening, everyone. This is a case of a 22-year-old female patient, Madam, with a 3-year-old kid, who presented with complaints of shortness of breath, presented in shock. She was primarily admitted at another tertiary hospital where she was being treated for septic shock, lower respiratory tract infection, thrombocytopenia with hypoxemic respiratory failure. So when we received her, she was already on norepinephrine, vascular, and dopamine. And she was maintaining SATs around the 90 to 92% with nasal cannula and oxygen on 4 to 5 liters per minute. On admission, her GCs was 15 over 15, but she had generalized anasarca and she was highly tachycardic. Upon admission to the ICU, so there's a ABG also. If you can.
You want ABC, yeah? Okay.
Yes, sir. Yes, so the first ABG on the extreme left side of the screen, that is at room A. That's a VBG. So the pH is okay, but then she was highly tactic and she had hypoxemia. So when she shifted to ICU, we put her on high flow mask. Then the second image again, that's also a VBG. So we had a hard time. She was a very obese patient, very obese, probably around 105, 110 kgs in weight. So we had a very hard time taking out the blood samples, especially the arterial blood samples.
Yeah, please continue, Sumit.
Yes, sir. Yes, sir. So then we started on hypnomas. Then she was maintaining saturation on 94, 95, but then she was still packing. So we put her on high flow nasal oxygen with pressures, I mean, a flow of 60 liters and FiO2 of 70%. Then the saturation came around 98, 97, and the tachypnea settled a bit. But then she was still tachypneic to begin with. Uh, we send the blood culture, we send the samples. So if you can show the cumulative, there's a blood report.
You want to send blood reports. Okay, I didn't get blood
Yes.
reports, Dr. Sumit. You can tell orally.
Oh,
Okay, you can tell.
all right.
Uh,
On admission, her the platelet counts were 18,000, hemoglobin was okay, TLC counts were 28,000 with the MCV of 114. But she had PV bleed as well, so we had to transfuse 1 unit SDP. INR was around 1.48, so we gave her 4 units of cryoprecipitate. Uh, the condition was a bit better compared to the admission, and you can see here, antifluvial was around 6,789, but then we repeated that, it came out to be 14,000 the next day. The echo that was done on admission, bedside echo, there was no RWA with LVEF of 45%. Local was 8.09, rose up to 11.3. All the reports were negative except typhoid IgM was tested positive in our hospital. So we had, and the patient received meropenem, tartroside, nitrogen, doxy, hydrocot, and other supportive treatment in the other hospital. So we started on meropenem, tartroside, and we added doxy also. And progressively, the patient developed severe respiratory failure. We have to take on IV support now. And with increased vasopressor requirement, I've sent your X-rays very nice in the next slide. Yeah, this is the chest X-ray. And these are the subsequent ABGs. He was doing a bit better, but then on the next day, next morning, around 2:30 in the morning, she developed severe respiratory arrest, where bradycardia and asystole. So we have to do CPR. We did 3 cycles of CPR on revive. But then after the patient was revived, there was no the the Jesus was still very poor, so we kept assessing the Jesus every 1 hour. Then on noticing, we noticed the pupils they were swollen and dilated and fixed. We wanted to get a CT done, but then since the patient was on so high vasopressor support, we could not get the CT done. We repeated the echo, The echo showed RWA local hypokinesia with EF of 15 to 20%. So we came to the conclusion of viral myocarditis. We got the cardiology reference done. Yeah, that's the best idea. RWA of 20-25%, IC. Yeah. Subsequently, unfortunately, the patient succumbed to the illness. Uh, so this was, in a way, it was a very vague type of case because I did not get much time to, get the whole thing done. Besides, the patient was with us only for 2 days, and there was hardly we could do to change the condition.
Okay. Okay, Dr. Sumit. Um, okay, you can keep yourself mute actually, there is some background noise there.
Right, so do that.
Yeah. What Sumit has explained here, okay, this patient, am I audible? Am I audible?
Yes, sir, you are audible.
Yeah,
Yes, yes.
this because he didn't get much time to put it in put it in detail. Just he has come up with one difficult case here, obese patient, okay, non-hypertensive, non-diabetic. Yeah, with fever since generalized fever since 17/8/25, generalized body ache, and breathing difficulty since 2 days. Okay, and PV bleeding is also there. Brown color vomitus. Basically, bleeding manifestations are there here. So, okay, tertiary hospital was septic shock. He's already mentioning septic shock. Okay, lower respiratory infection, hypoxemia, respiratory failure. This is a very important terminology, septic shock. Tachycardia is there, hyperthermia is there, BP is with norepinephrine, vasopressin, dopamine. Oh my God, it is all three vasopressors. Saturation is low with nasal cannula. How much? 4 liters. So hypoxic. So GCS is relatively okay. Edema is there, tachypnea is there, dehydration, anasarca and dehydration. Can you see this? Dry mucosal tongue, tongue is dry, skin turgor within normal. You are good thing you are checked for skin turgor. Auscultation by blood Krebs is there, hematomegaly, okay, and count C is up and platelet is down. Basically, is a thrombocytopenia with some infection. Okay, so we can call it as sepsis. We have to know the definition of sepsis here. What is the definition of septic shock? Okay, now we are not using the word severe sepsis. We are using either sepsis or septic shock. And echo is normal, means no reason, but earlier 45%. I think it is deteriorated 20% after a few days. Uh, Typhoid has come positive here. Dengue, all other is coming negative. Dengue is negative because of thrombocytopenia. They have put on multiple antibodies, meropenem, targocid, metrozil, hydrocod. Even we will discuss about the antibiotic, how to select antibiotic here. We'll discuss that part. So basically, if you go to the next slide, you see there is a lot of haziness, bilateral haziness is there, even effusion also. It looks like a ARDS, okay? So we have discussed a thing. Here I want to notice all of you, just before the discussion starts, I think Dr. Mahadev is also there. Can you see here, there is hypoxia is there. So they have tried, NIV, this one, high flow nasal oxygen and intubated later. You can see, look at this, lactate is 5.3 here, increase 7.1, increase 9.9, increase 12.2, increase more than 15. Can you see here, lactate is in this. I want you people to just see, pH is dropping, 7.5, dropping here, increased here because of maybe washout of carbon dioxide, again see 6.80. But later again, after ventilation and all, they're able to maintain the pH. You can see here 6.9 and 7.09 and 7.32. But look at the lactate is not increased, not improved, only more than 15, 10, 14. It's like same thing. Just with this background, what myself and Dr. Mahadev thought
అంటే
of.
ఏం చెప్తుంది మేడం క్లాస్ తీసుకొచ్చారు
Okay, please mute yourself.
ఏమంటారు ఏం చేయాలంట
Please mute yourself.
నీకు ఎక్కువ నాకేం తెలిసి ఉంటుంది సార్ అని మీ ఇద్దరికే బాగా తెలుసు నాకేం తెలియదు అని చెప్పు
Okay. Okay, I think I'm audible. Now, what we'll do, what we thought before there was a presentation was there was a delay. So we thought we discuss about the how to give fluids in septic shock. Okay, that we will discuss first now. Okay, along with this case. And meanwhile, I'll take this case again. So how to, uh, sorry, I want to share here. I share and we'll come this case. Okay, we'll discuss the case again in between. Okay. Can you see the slide? Can all of you see the slide?
Yes.
Yes, sir.
Okay. This is a fluid restoration with respect to septic shock. We will discuss your case again because there was a bit delay in getting the slides. We, myself and Dr. Mahadev thought of discussing about shock, septic shock, how to give fluids. This is the most important topic, how to give fluids. The if you are able to identify, if you are able to identify fluid by giving fluid, if which one to choose. There are a lot of fluids are available. If you see here, we have crystalloids are there and colloids are there. In crystalloids, we have many. NS is there, RL is there, NS is there, RL is there. Now we have balanced our solution. We have balanced our solutions are there. So many fluids available. And colloids, we have etastarch is there, and gelatin is there, albumin is there. And next question is how much to give. So we'll discuss only these 2 points here. How much to, what to give fluids and how much to give. Quality and type of fluid and quantity of fluid. We'll discuss these 2 parts. This definition of sepsis you should all know. It is a life-threatening organ dysfunction caused by dysregulated host response. This is very important. Dysregulated host response. You should know the definition. This separate septic part, if time permits, we'll discuss again. We'll straight away try to, I want to push for fluid resuscitation. That is very important in this patient actually. Septic shock should be defined a subset of sepsis. In particular, profound circulatory, cellular and metabolic abnormalities are associated with the greater risk of mortality than sepsis alone. When you call septic shock, when you have given patient is sepsis patient is there, sepsis means if the patient is having dysregulated host response due to infection, probable infection or suspect infection, okay, that is causing the BP drop in BP, you start giving fluids here. In spite of fluids, if BP is not improving, or you want to start noradrenaline or adrenaline or vasopressin. In this patient they use dopamine also. If you want to use, there was a need to use these medication, means it is septic shock, means BP, there is hypotension in spite of fluid restoration, that is septic shock in sepsis. Okay, so with this understanding, we know the mortality, very high mortality if it is involving other organ failure, especially renal failure. It mortality increased to 62, even sometimes 70% or 80% also. Now I'll come to the Survive Sepsis Guidelines 2022, 21, recent. Even though these are old slides, I want to put for the recent guidelines. See, when a patient comes with this patient comes with the septic shock. He mentioned, Dr. Sumit mentioned septic shock. What to be done? So, moment you found that there is a septic shock is there, I told you how to identify septic shock. Any patient with the sepsis. How to know sepsis? There should be some systemic inflammatory response. There may be tachycardia, tachypnea, hyperthermia, okay, and leukocytosis. Okay, any two of these four findings are there. If it is due to infection, probable or suspected infection, that is sepsis. And there is patient has come septic shock. This patient has come with septic shock, means you have given fluids, BP is not improving. Then we can call it a septic shock. How much fluid? We'll discuss that part. So this is emergency. As we see in the MI patient comes, what we'll do, usually you think of ECG will take within so much minutes, and you start identifying either STEMI or NSTEMI, start giving bolus doses, ecosprin, antiplatelet, especially ecosprin, clopidogrel, enoxaparin, okay, then atorvastatin, then planning to either go for angio or not. So there is some systematic approach is there. Same way, we need to have some systematic approach here. And this approach should start immediately. It's very important, immediately. So at ER, if the patient is in ER, start in ER. If the patient in ward, start in ward. If the patient in ICU, BP is dropping because of infection, start ICU, start in ICU. So this is called best practice statement, means guidelines. So no need of guidelines for this actually, we have to start. Why? Why you have to start treatment early, especially fluids? Why? Because effective fluid restoration is crucial for the stabilization of the sepsis induced tissue hypoperfusion. What is happening here in the sepsis and septic shock? So cell is not getting oxygen, cells are not getting oxygen. Okay, there is a oxygen want more, a cell want more oxygen, the demand is high. Because why demand is high here? Because there is a infection causing septic shock, causing hypoperfusion to the organs. It may be kidney, it may be liver, it may be lungs, it may be brain. There may be no perfusion or reduced perfusion to the organs. So oxygen delivery will be reduced and demand is high. What happens? Cell will die. If you are not giving right time, if you are not maintaining the timing here, if you're not giving immediately, if you start not giving fluids, not maintaining BP, not giving oxygen, means it can cause further hypoperfusion and cell death. If kidney cell death, means it is a renal failure. If brain cell death or hypoperfusion brain, can patient be irritable, restless and comatose. If oxygen to the lungs, heart, hypoperfusion heart can cause MI or AC changes or maybe liver failure, something like that. So any organ failure can be applied because of the in time if you're not giving fluids. That is very important. So you have to start it early. Okay, so I want to highlight the even the guidelines also. Next comes to the which is the ideal fluid, what fluid should be given. So in this patient, as Sumit was mentioned, already started a patient, I think came from outside, started on noradrenaline. But before starting any vasopressor, you should see whether fluid is given adequately or not. If you feel fluid is not given adequately, you have to select the fluid. So how to select, how any patient with septic shock? See, if you the moment you know the patient is in infection, BP is dropping, means he needs fluids definitely. So guidelines mentioned 3 liters of fluids. Okay, that term, I'm sorry, 30 ml, 30 ml per kg, 30 ml per kg of fluids. Okay, that amount of fluids is required for that patient. But as intensivist, usually we no need of gadgets here. When the patient comes septic shock, start giving fluids. How much to fluids? You have to use your assessment. Okay. So which fluid? First I'll talk which fluid. Ideally should be there in the intravascular compartment. It should not go to the interstitial space and cause more edema. Should not result in metabolic complication like metabolic acidosis. Normal saline will cause metabolic acidosis. Normal saline, it is not normal. The saying is normal saline is not normal, it is abnormal because it can cause hyperchloremic metabolic acidosis. Doesn't mean you should not use it. We should use it. We should know when to change to other fluid also. That is important. And hyperkalemia. Okay, sometimes RL can cause hyperkalemia. Okay, should not have any allergic manifestation. Should not induce coagulopathy. This gelatin and another one drug. What is that? Hemacil. This is called coagulopathy and must be inexpensive. All colloids are very much expensive. Patient should be inexpensive. So what we are discussing here, we should know the fluid is the ideal fluid. But is there any ideal fluid is available in routinely? What we say? See, these are the crystalloids. You should know this one, crystalloids or colloids. So most of the patient can be managed either by giving crystalloids only. So in crystalloids, we have normal saline, balanced salt solution like a ringer lactate, plasmalite, cabalite. These are the names of the companies, plasmalite and cabalite. And dextrose is there, 5% dextrose, 3% normal saline, hypertonic saline, and 7%, 5% normal saline. These are the, crystalloids. Okay. In this, okay, these drugs can be used in the, in the head injury and all. Even before patient coming to the ICU itself, we can use these in head injury. But in the septic shock point of view, we can use this. Usually, dorsal we use ringer lactate, and sometimes use plasmalite also. But in colloids, we have albumin 5%, we have 25%, we have hydroxyethyl starch and gelatin. In hydroxyethyl starch, we have pentastarch and hetastarch. Are anybody using pentastarch, hetastarch, hydroxyethyl starch? Or anybody is using these drugs, these fluids?
No, sir.
Okay. People still use this hydroxyethyl starch, especially anesthetists using in the ICU. And gelatins people use should not be used. I will tell why. You can use albumin if you want. Okay, you can use albumin, but these should not be used. So with these fluids, so many patients with septic shock. Here the patient comes with the severe breathing difficulty and shock state. What fluid to be selected? We have so many options. So what the guidelines mentions, you can go through this study, hydroxyethyl starch versus saline by American New Zealand Intensive Care Society. Whenever these people will do no ANGIX trial, Australian New Zealand Intensive Care Society ANGIX trial. These are beautiful trials. Please consider it. They found that there is no difference if you use either saline, no difference in mortality if you use, saline or hydroxyethyl starch. With respect to mortality, nothing is there. Okay, and more patient is hydroxyethyl starch. Earlier we have used main hydroxyethyl starch like the 2010. You can before 2010 I can say 2006, 2005. Lot of fluids hydroxyethyl starch, hetastarch is used. But if you look at the problem here is you have to remember this when you use this hydroxyethyl starch, there is an increase in the kidney failure, that is called renal failure. Like if you take a score of Rifle criteria, risk, injury, and failure all will increase. If you use hydroxyethyl starch, and there is a coagulopathy is also there. So basically, what I'm telling, it causes problem to the kidney. Patient will have worsening kidney renal failure. Okay, if you use hydroxyethyl starch. Okay, and statistically significant also, very much statistically significant. So we cannot use hydroxyethyl starch because there is no difference in mortality and causes problem, especially renal failure. This you should know. You can see in this graph also, hydroxyethyl starch creatinine is increased significantly, and here it is, and urine output also reducing significantly. Basically, creatinine significant. So means we should not use this. You know from these slides, if you remember this, in 2021 guidelines also mentioned that okay, we should not use septic shock. Use of starches for resuscitation against should not be used. Now, if anybody using starch, stop it. It can cause renal failure. It can cause renal failure. So, in septic shock, what we are doing, we are selecting fluids and also avoiding the most important injury, kidney injury, as kidney injury itself can cause, mortality. Mortality jumps from 60 to 80%. So because of this, we are avoiding renal failure by avoiding straight away starch. Basically not required, and it is expensive also. Coming to the gelatin, in same way, we cannot use gelatin here because gelatin also can cause, coagulopathy and all. It is against use gelatin. Okay, stop using gelatin in septic shock. These are almost since 20 years we are telling the same thing. Now we have to stop. If anybody using these drugs, it is time to stop these drugs. Why I am telling, fluid as drugs? Fluid should be used as a drugs. Remember this, fluid is not just a one some fluid which can be given continuously, like a something called what is that? Maintenance fluids. There's nothing called maintenance fluids. Don't use like a maintenance fluids. If fluid is required, use it. If not required, stop it. If it increase, remove it. That's it. Don't use fluids unnecessarily. Fluid is a drug. As you use carbapenems, meropenem you was using, targocid you was using in this patient. So as you drug, you are how you use measure drug. You use the drug injection meropenem 1 gram, okay, IV over 3 hours infusion. You mention like this, no? You have to mention like this: fluids, normal saline 1 liter over 4 hours, or 250 or 200 ml per hour over 6 hours, or 100 ml per hour over 5 hours, something like that. So it should be mentioned with the dose, quantity, and timing. This is the important study you have to remember. Safe study. If you compare saline versus albumin, it is a landmark trial. Earlier studies have shown that albumin can kill the patient. Albumin increase the mortality, but this study showed that if you use saline or albumin, there is no change in mortality. So among colloids, which can be used? We can use colloids. Both are safe. Saline versus albumin, both are safe. But if you see the albumin and saline, because it is quite costly, albumin, Australians use albumin very much actually, but we use more of saline or crystalloids we use. So when come to the cost and there is no mortality benefit is there, why to use albumin? So that is the thing. Usually we use crystalloids. You can use albumin also, but it is costly. This albios trial then came after this trial, albios trial. This trial also found no mortality benefit if albumin is in combination with the crystalloids compared to crystalloids alone in septic shock. Means if you combine albumin, there is no mortality benefit. They're mentioning 5% albumin. See here, it is a 5% albumin. But in subgroup, they found that lower 90-day mortality. So in patient where you want to give large fluid resuscitation, significant fluid resuscitation you want to give, okay, only normal saline is not helping, you want to give more and more fluids, you can add albumin. That is another advantage of albumin. That's it. Albumin, usually albumin and salines are both are safe to use, but no mortality benefit and cost is high, so we are using saline or hanger lactate. If you are using large fluid resuscitation, you can go for adding albumin also. That is the albios trial. So fluid therapy. So which one then? So which one? Now we know that crystalloids. Either we can use albumin or crystalloid, but we use crystalloids for initial resuscitation of subsequent initial resuscitation and subsequent volume. Okay, in patient septic shock. So in crystalloids, coming to crystalloid, which one to use? Which drug to be used? That is important now. So there are, again, you should remember, there is a chloride liberal fluids. These are chloride liberal fluids and chloride restrictive fluids. Okay, chloride restrictive fluids and chloride liberal fluids is there. Okay, here you can see chloride is 98. Here you can see in normal saline, if sodium is 150, you should remember this, chloride will be 150, but here plasma light it is 98. And ringer lactate Hartmann it is 109. So these are called chloride restrictive fluids. Which one? RL and plasma light, and now we have cabilite and all. Okay, but if you look at the saline, it is a chloride liberal fluids. Why you are worried about chloride? This chloride, okay, if you go when it enters the fluids, actually what happens? Okay, if you give more and more normal saline, if you imagine if 1 liter contains 150 milliequivalents of chloride, if you give 10 liters of normal saline, there is a 1500 milliequivalents of chloride ions. What happens? This causes renal vasoconstriction. Okay, in the kidney, it causes renal vasoconstriction. So renal vasoconstriction causes hypoperfusion to the kidney. It can cause kidney problem. Has it proven? Some studies, recent studies, as towards more for this actually, but we need strong evidence for that. But while you should remember these chloride ions, we cannot just add chloride, just add normal saline to the patient, can cause chloride can cause kidney problem because of the chloride restriction. So in this aspect, there are so many trials have come actually. You can see this salt trial, and another one is salted trial is there. Salt trial and salted trial. If you use saline and balanced solution, there is no mortality benefit. But if you look at the make 30 means it is acute kidney injury events. Okay, major acute kidney injury events are higher with the saline. So kidney injuries are higher with the salines. Not significant, not significant in the sense there is no statistical significant. Smart trial, another trial. This is a recent trial again. Recent means it is already now 2018. Smart trial, 0.9% versus cabulite found that balanced crystalloids in lower is a lower rate of composition of death, renal replacement therapy, persistent renal dysfunction. This is called MAKE, major adverse kidney injury events. Major adverse kidney events are reduced. So death is reduced, renal replacement therapy is reduced, and persistent renal dysfunction reduced if in case of balanced crystalloids. So it is not statistically significant. Again, I am telling 0.04. But if you use, imagine if you use multiple doses. If you imagine, if you here if you see balanced crystalloids or saline, if you use more and more fluids, if you imagine in the whole or how they will predict is, if you use 5 million patients all over the world, if you use more and more fluids, if you that amount of fluids, then there is a reduction of death, renal replacement therapy, and renal dysfunction. Means large volume can be it can cause problem. So how to take it in a bedside actually? This is again this is the same thing. Again, this is the balanced crystalloids versus saline. There are so many studies have come with use balanced crystalloids, lower incidence of major adverse kidney events. So how to put it clinic when bedside is, so use crystalloids as a first line. Among crystalloids, start with normal saline, okay, 30 ml per kg fluids. If patient require more and more fluids, then we can switch over to fluid restrictive fluids, that is RL or plasma light or cabin light, something like that. Balanced crystalloids. These are all balanced crystalloids. Balance means is almost equivalent to plasma. Chloride is almost equivalent to plasma. So this is the message from these slides actually. So what I am telling here is, so we can use crystalloids. Among crystalloids, balanced crystalloid instead of normal saline. If you want to use large volume resuscitation, now it has come into the in the 2021 they have put it like this directly. They have put it weak recommendation. We suggest using balanced crystalloids instead of normal saline when you are using large volume. We cannot remove normal saline. When you want to use large volume resuscitation, then we can go for balanced solution. But now the recommendation is already, earlier it was maybe it was used something like that. Now they are telling directly suggested. So this is about the fluid, which one to use. Don't use colloids like a starch and gelatin, albumin if large volume resuscitation required. Use normal saline or RL. Okay, if you want to use more and more normal saline, then we can switch over to balanced solution like RL and what we call plasmalite or capillite. Suggest using albumin. 21 guidance suggest using albumin who received large volume of crystalloids who are using crystalloids alone. You can add albumin also. Even in ARD is also helpful. So now come to the how much to use. This is an interesting point actually. How much to give fluids to be given? Which one you know now? How much to give? This is if you go to the this trial you should know 2001 by Rivers et al. Early guided therapy. Early guided therapy means when he patient septic shock, what he has to do? He started giving fluids according to some guidelines. Okay, what guidelines he maintain? He measure CVP. Now we cannot measure CVP because we know CVP is useless. He measured mean arterial pressure to maintain more than 65. He maintained CVP 8 to 12, and urine output he maintained more than 0.5 ml per kg per hour, and SCO2 means subclavian oxygen or central venous oxygen saturation more than 70%. He maintained these guidelines and found that there is a mortality benefit. It is very much true. Now if you maintain the same guidelines, you may not get the outcome because we have already improved the standard of care. In last 24 years, we improved the standard of care to the extent that now everybody is giving fluids and we are already in the highest standard of care. So we may not get, if you do the same study, we may not get the mortality benefit. But in 2001, this is a significant mortality benefit. We started using, as I am a resident in critical care, I started using this guidelines and we found a lot of mortality outcome. This was like this. Okay, what we have to do is, we have to, if you know this, we have to put central line and arterial line here, put central line and arterial line, measure CVP and this one. Okay, if CVP is less than 8, we started giving crystalloids. We wanted to maintain 8 to 12, but now recent guidelines showing that no need to use CVP. It is very clear. Now we'll tell what to be used, we'll tell that part. And we used to measure mean arterial pressure if we want to maintain more than 65. If less than 65, we started using noradrenaline, and even in that case, dobutamine is also there. If it is SCO2, then we used to measure SCO2. Means you have to put a center line and see the VBZ from the center line and look at the SpO2 in that. Saturation in that ABZ. If it is less than 70%, if hemoglobin is less than 10, we used to give PCV to improve the oxygen delivery. If hemoglobin is more than 10, we used to add dobutamine. This was the standard in 2001. We can say 2010. We all learned this technique only, but now we are not using this. So what I want to say this found that there is a significant mortality benefit. This is very important. So now we all know that CVP can't be used. So these are called CVP and pulmonary arterial occlusion pressure and right atrial pressure, right ventricular pressure, right ventricular end diastolic volume, right ventricular end diastolic pressure. These are all called static pressures. Left ventricular end diastolic volume, left ventricular end diastolic pressure. These are called static pressure. Static pressure will not tell whether to give fluids or not. This is very important. Even though CVP less than 8 and mean pulmonary arterial oxygen pressure less than 12, positive predictive value means 47%. Means if you give fluids, 47% only you are right, 53% you are wrong. You may give more fluids or pulmonary edema. So that is important of this CVP. So we are not using CVP. There are n number of studies have come up here. So what we are using here, we use pulse pressure variation instead of static pressure. We use this is a static pressure. We use this is a static pressure. We use pulse pressure variation. Pulse pressure variation. Yesterday, last class we have discussed here. These dynamic measures. These dynamic measures are the now choice of the measurement, I can say, when you give fluids. Don't use static pressures. These measurements perform better than the static measurements. So you have to measure the either pulse pressure. How to measure pulse pressure, we can discuss that part. Pulse pressure variation is more than 30%. We can give fluids, okay, easily. 94% sensitivity, 96% specific. Means 96% you are right that you are giving the fluids to the right patient. So that is the importance of pulse pressure variation. Always measure this. So in this patient, you have to give fluids. What your selection, I am told actually how much to give according to the pulse pressure variation. That's how you should see. So there is again so many guidelines have come. This is a process trial, okay, process trial, ARISE trial and PROMISE trial. They use 30 ml per kg as initial fluids, 30 ml per kg as initial fluids and 2 liters in this PROMISE trial. They found that these studies show that if you use early goal therapy as used in the reverse et al, not much helpful. Is that they are telling that early goal therapy is not helpful, means we cannot measure CVP and all. How to measure? Go with the dynamic measures, identify whether the patient is fluid requiring or not, then give fluids. Just by selecting the patient whether to give fluids or not, we can manage this septic shock very easily. This is the very important slide. If all are okay, able to understand what I'm talking? Hello?
Yes, sir.
Okay, if any doubt, you can ask in between. If you remember this Frank Starling curve, you can manage any patient. In this patient, I tell, I think who spoke about that case, Sumit, how to give fluids, and he used noradrenaline, dopamine and all. We won't prefer dopamine. We won't prefer dopamine. We start noradrenaline, we will add vasopressin. Still require, we use adrenaline. Okay. But whether before starting vasopressor, whether we are given fluid, whether we want to give fluids or not for that patient. So for that understanding, you should know this is the Frank-Starling curve. Remember this Frank-Starling curve. This is the normal heart. This is the normal heart. Means normal ventricular function. This okay goes up like this, then become plateau. Okay. If we want to give fluids, you have to give fluids at this stage. If you give fluids, already patient is having plateau, so patient will not respond, will go for fluid overload and pulmonary edema. So that is important. Okay, imagine this is A and B. So I am giving fluids 500 ml here. 500 ml fluids I am giving. So if I give 500 ml, okay, if the stroke volume increases to A dash to B dash means I am giving fluid to the right patient. Okay, 500 ml means I am giving fluid challenge. Okay, I am giving fluid challenge means large amount of fluids, 1 to 2, 1 liter, 500 ml, very short duration, 10 minutes, 20 minutes. Give fluids and see whether the BP improves or not. Especially, actually, you should see the stroke volume improves or not. If that is improving means the patient is fluid responsive. So means I am actually basically patient is at this part of the curve. Okay, if I am giving the same 500 ml here at this part of the curve, already patient is filled with volume. There won't be increase in the stroke volume. If you give fluids at this part of the curve, the patient may end up with the pulmonary edema. So we should know we are selecting the patient at the right part of the curve, Frank-Starling curve. If the patient is in heart failure, poor LV function, if I give a same 500 ml, see the stroke volume will not increase at all. It is hardly increasing by 10 ml, 20 ml. Means if I give fluid, stroke volume will not improve. This patient go for pulmonary edema because the patient is already in the plateau phase of the Frank-Starling curve. This is very important. Imagine if the patient comes to you, you are given almost 3 liters fluids in the evening time. Night doctor is coming and seeing whether the patient is in which part of the curve. Patient may be already in this part of the curve. So every time you have to reassess the patient whether we are giving fluid adequately or not. To know this, I can't give fluids and see whether patient will go for pulmonary edema or not. So I cannot give fluid and a fluid challenge test and see whether patient is having fluid response or not. So in that case, we look into different parameters. But I mentioned static parameters are useless. So we are measuring dynamic parameters. What are the dynamic parameters? So we are using pulse pressure variation. As I discussed in the last class, we are using pulse pressure variation, or we are using end expiratory occlusion test, and we are using passive leg raise test, or we are using mini fluid challenge test like 100 ml, whether the patient is fluid responsive or not. So basically, mainly we are using pulse pressure variation to know the patient is fluid responsive or not, but pulse pressure should be more than 13% to tell it is a to give whether the patient is fluid responsive or not. It should be more than 13%. So we can see the arterial curve here. Arterial curve should have a lot of fluctuation like this. Then there is pulse pressure variation is there. If arterial curve is uniform means there is no pulse pressure variation. Here we can give fluids. We can calculate also, or we can monitor pulse pressure variation. Now we have monitors. We can monitor pulse variation. If it is more than 13%, we can give fluids. 96 to 98%. You are right. You are giving fluid to the right patient and right time. That is the advantage of dynamic measures. Don't use CVP and all. That is important. The moment you give adequate correctly fluids, so the end organ damage will be reduced and we can avoid all trauma. So heart with avoid all the failure and organ failures. Heart with normal function can maintain adequate output with very minimal preload or stretch. A failing heart cannot maintain adequate output. These are all my teachers' wordings. Actually, I am using the same one. We optimize preload, we won't normalize. Nothing called there is normal preload. Same thing is depicted here. If I give a small 500 tidal volume, if you is in the peak part of the curve, okay, if you in the peak part of the curve, there is a very good fluid response will be there. Patient, we can give definite fluids. If you are giving fluids at this part of the curve, we cannot give fluids. Patient will be. So what is preload responsiveness? Preload means responsive means if you give fluids, okay, adequate stroke volume we are getting. Okay, This is the failing hearts. You can see the same fluids. There is no improvement in the stroke volume. So we are checking here the ability of the heart to increase the output when the preload is increased by fluid boluses. That is called preload responsiveness. So can I give fluid challenge? We cannot give fluid challenge for all the patient, and see if patient is not responding, we patient go for pulmonary edema. So we have to use the fluid challenge can cause pulmonary edema and increase the mortality in case of ARDS if you give more than 4 fluids. So we have to use phasic change in the LV function, pulse pressure variations. That's very important. If it is more than 30%, we can give fluids. But if pulse pressure variation, you can see here, as I mentioned already, they explained this in last class. If it is more than 30% means here we are actually curve will look like this. If it is part of curve, there won't be many fluctuations. Hardly it's 9% here, 26%. You can give fluids here. Why I'm giving fluids? If you know how to manage fluids, you are well versed with the critical care management. Any patient you can manage. That is very important. Again, I'm repeating the same sentence here. You can use IVC collapsivity index. Many people use IVC diameter. Don't use IVC diameter. So diameter is useless. You check the collapsivity index. So this is the there should be more than 50% collapse. Rather than collapse, you check the IVC collapsibility index. I'm sorry, IVC collapsibility index. There is a formula is there. Expiratory diameter minus inspiratory diameter divided by expiratory diameter. I will see those part later actually. So IVC collapse index you can test. We can even do passive leg raising test. There's a technique called passive leg raising test. So we'll discuss this part again because time is not permitting me. So we can, if it is passive leg raising test, and you have to use the aortic flow velocity index to know whether the patient is fluid responsive or not. So we'll discuss this part. So what the guidelines mentioned here is it is a medical emergency, start fluid immediately. So at least 30 ml per kg. See, should be given first 3 hours. At least if you don't have a gadget, just give 30 ml per kg over first 3 hours. We can save many lives. Many times what happens, we are not giving fluids adequately. We are giving fluids after 48 hours, after 24 hours. Then fluid may not be helpful. When fluid is required, early is the key. You want to give fluids, give it early. Later, patient already organ failure is there, fluid may not be helpful. Again, guidelines clearly mention that use the fluid restriction over physical dynamic measures. Okay, in this dynamic measures we can use stroke volume variation, pulse rate variation. We can use it, or echocardiography also we can use it. And another point here, lactate. I told you, look at the lactate. You can use lactate as a guiding restriction to decrease the serum lactate. If lactate is decreasing, means your patient is improving. It is a very good prognostic parameters. But make sure that lactate is not arising from any other drug. Sometimes it may be drug induced also. Okay, maybe adrenaline overuse can cause this serum lactate. But most of the time is a reduction in the lactate means there is a good prognosis. So if you don't have anything if you are low resource setting, then you can use at least capillary refill time. He used capillary refill time to adjust to the perfusions, and we can give fluids. So we cannot give more fluids also. More fluids can cause hypervolemia, can cause more harm actually. Excessive hydration. Sometimes after giving fluid resuscitation, after 3 days, 4 days, we give diuretics to deresuscitation. Something called resuscitation, deresuscitation is also has come now. So we do that also. So basically what I want to say is, in septic shock, how to give fluids and how much to give fluids. I told this part actually. I will stop here. I want to ask question, and I will take the case again. If any doubt is there, we are very happy to discuss. If Dr. Mahadev is there, he will also be there to discuss. Any questions you want to discuss? When blood loss is acute, blood and blood bank from the blood gets delayed, we start OT. Yes, sir, we use. What is, I don't know, Nesra, what she want to tell. I think she is using, Nesra, are you using?
No, sir. The answer for another question, sir.
What is that question?
It was just audible, and I just wanted to tell you that you are clear and audible.
Okay, okay. Don't use that actually. Where is that case? Yeah, this case. Uh, Dr. Sumit, right?
Yes, sir.
Yeah. Just to see, the thing I want to highlight here is so usually what we do, we use more and more norepinephrine, vasopressin, dopamine. Don't use dopamine now.
So she came on dopamine. We didn't use dopamine. We started on
Then what
ADR.
you do is, if the patient is spontaneous breathing, check for the IVC collapsibility. If it is more than 50% or IVC collapse index is there, you can see the formula there. If it is more than
Yes, sir.
50%, start giving fluids. Okay. And if the patient is on ventilator already and patient is sedated and not taking spontaneous breath, then if you put arterial and already is there, check for the pulse pressure variation. If pulse pressure
Yes.
variation is significant, start giving fluids and try to remove this medication as early as possible. Okay, that is the one thing. The moment you start, no, what actually you are doing is actually patient needs fluids in septic shock. Actually, fluids means
Right.
actually what you are giving oxygen. See, optimizing oxygen is the key. Septic shock means it is that oxygen delivery. As in the reverse etology mentioned, you wanted to see the SVO2. Why is you want to maintain 70% SVO2? Because you want to give more and more oxygen and see that even venous oxygen maintains 70% means oxygen delivery,
Yes, sir.
oxygen to the delivery is optimized and oxygen cells have taken adequate oxygen, and when come to the venous channel it should be 70%, means if you give 100%
Yes.
oxygen, at least cell should take as much as oxygen. So you want to maintain 70%. Okay, you are getting this point. If the patient is in early failure, cells need more oxygen, so you have to optimize oxygen delivery. If the already cell is death, cell died, means if there are already renal failure or liver
Yes.
failure, already organ failure is there, even though if you maintain oxygenation, cell is not taking any oxygen, whatever the oxygen you are given, it come to the venous channel, it may increase more than 70 also, means later if you resuscitate, this is not helpful. If you want to resuscitate, you have to
Okay.
resuscitate early. Okay, I think I'm not confusing because of the time factor. No, we cannot tell too much things here. So, and another thing is telling your dehydration. Even though you are telling anasarca, you're telling dehydration, diuresis. I think you can give more fluids here. And this is the platelet count. I doubt here typhoid has come positive, means easily we can manage with antibiotic here. Very
Nice.
not requiring very higher antibiotic here. Adequate broad spectrum antibiotic. Even we discuss about antibiotics later, how to use antibiotics and all that we can discuss.
Right.
Anything else to discuss here?
Sir, album was two. That's why maybe she was there was
Al-
another.
Albumin was 2. Huh.
Yes.
Why anasarca means he telling albumin to whatever you are giving fluids, it is going for the extravascular space, correct? No?
Yes.
And going for
Yes.
anasarca.
Exactly. Right.
Yeah. Then you can give albumin where you giving fluids. If these are the patient, you
Yes.
can give albumin along with the
Yeah, we started on album. So
yeah. You can maintain, but that's what now recent guidelines mention. If when you are giving large amount of fluids, actually whatever you crystallize, it going to the interstitial space only because lot of epithelial leak will be there. But till we want to give more and more fluid, don't give colloid. There was a colloid theory was it will retain in the intravascular space, so you are using colloid, something like that. Now that theory is not there. Give crystalloids only. If you want to use more and more fluids, add albumin and go for balanced salt solution.
right.
So that is
Right.
one thing.
So, what it ask you if
Any other
if we
questions?
can so N by two can we use N by two in ICU and how often can we use N by two?
Pardon, who is talking this? Sumit,
So, Dr. Smith,
yeah. Tell me.
so IV fluids can we use N by two and how often can we use N by two?
End of tool.
Sir, N is 0.45%.
INR is 0.4%.
Yes,
INR,
sir.
you are
N
talking about
is
INR,
no, sir. N is 0.45%
I
in ICU.
think
You are
I
talking
think
about
sir he's talking about half saline.
half saline.
0.4. Yes, yes.
Okay, okay, I will
Yes.
discuss. Okay, this is the see dextrose 5%, half normal saline Okay, don't use this in sepsis, any resuscitation. Okay, never use this.
Right.
If you use dextrose, actually nothing is there. Dextrose means glucose will be utilized by the cells. You have left with only free water. Nothing stays in the intravascular space. It will go to the interstitial space. Actually, you are worsening edema. Okay, what is happening? The more and more edema worsens. No, imagine this is the intravascular space. These are the cells. Okay, the more the edema worsens here. Okay, oxygen delivery to this cell will be easy, but oxygen delivery to this cell will be delayed as the edema increases. So don't put more and more fluids and increase interstitial edema. Especially dextrose, it causes more edema. Never use it. Half normals also same rules apply here. Always use normal saline. Okay, if normal if you want to use balanced solution, RL or plasmalite, cabalite, so many are there now. You can use any balanced solution. Don't use half normal saline. Clear, Sumit?
Yes, sir, absolutely. Thank
Okay.
you.
Any other question? Any other? I think I've gone a bit faster in the last few slides. How much to give fluids? If anywhere time any case discussion, I can discuss that part also. Anything else to discuss?
Sir, I have one question, sir. Out of all these tests which you recommended, like five,
Still pulse.
like mini fluid challenge test or passive lace test or this one, the IVC collapse, which one is the best you will recommend to be do?
PPV is the best. Okay, if the patient is rules apply here. Rule number one:
Mm-hmm.
sedated and relaxed or deeply sedated. We should be ventilated.
Mm-hmm.
First thing is should be ventilated.
Mm-hmm.
Okay, should be sedated and relaxed. First rule number one. Rule number two: tidal volume should not be low tidal volume. It should be like a 8 ml per kg.
Okay.
Not use 6 ml per kg and see the pulse pressure variation. Rule number three: there should not be right heart failure, pulmonary embolism, all those stuff should not be there. Should not be right heart failure. Okay. Rule number four: there should not be any arrhythmias. If these four
Mm-hmm.
parameters are met, if there is no arrhythmias, if there is no right heart failure, if there is tidal volume is 8 ml per kg, means no small tidal volume per kg, and patient is sedated, relaxed on ventilator, best. If the patient is spontaneous breathing, passive
Mm-hmm.
grazing test,
Passive leg raising test. Okay.
PLR. Okay, and look
Okay.
at the stroke
Mm-hmm.
volume. Do PLR, you just see videos and all. PLR, how it will done. If you want time permits, we'll discuss that later also, means next class. Do passive leg raising test. There is you should know passive leg raising test, correct technique. You cannot use just like that, elevate the limbs and all. We can discuss that technique later. And check the stroke volume. Up, put the artery line, check
Mm-hmm.
the stroke volume. If stroke volume increasing means use give fluids. So next is passive. This passive leg grazing test can be used in the spontaneous breathing patient or even in the ventilated patient also can be used. And there is another thing is mini fluid challenge has come now. Just use 100 tidal volume and see whether there is improvement in stroke volume or not. These are the two techniques you can use: PPV and
Okay.
PLR.
Okay. And sir, I have one question more. Like in some cases, in during septic shock, patient is on ventilator. We are giving NORADs, and patient is still not responding. What we should do the next?
You are using noradrenaline, BP is not improving.
Yeah, BP is not improving, or like you can say, maybe we are saying the 70 by 40 or 80 by 45, something
BP
like that, or
means, okay, I got
dropping.
it. BP means target mean artery pressure around 60, 65.
We are not achieving in that scenario. What we will
Don't
do
increase
further?
to 75 and 85. First rule number one. If
Mm-hmm.
BP is low, give fluids. Check all these PPV, pulse pressure variation, or passive leg grazing test, or IVC collapse index. I told no, IVC another one, very easy. We use it frequently, IVC collapse index. If it is more than 50%, just give fluids. Try to fill the volume. If you not fill the tank,
Mm-hmm.
okay, if you give vasopressor, no use, no help, no help. Try to fill the tank first. So try to give adequate fluids. Okay, while giving
All right.
fluids, BP is low, start noradrenaline. If noradrenaline is not, BP is improving, but make sure that fluid, again fluid, try to give fluid, make sure that fluid is filled, volume is filled. Still BP is low, give noradrenaline. While resuscitation, if you want to maintain BP, start noradrenaline. In spite of fluid resuscitation, BP is not maintaining, you have started noradrenaline, start injection vasopressin.
Okay. Means first fluid, then NORAD, then vasopressor.
Fluid is always there. While giving starting noradrenaline, fluid is there. While starting vasopressin, fluid is there. Always check, reassess IVC, RA-RV. You can see even RA-RV dilatation. You can look at the pulse pressure variation. Any technique you can use. Make sure that whether patient fluid response. Always remember this curve. Whether the patient in Frank-Starling curve, whether here or here. If the patient is here, fluid is done. Fluid work is done. If the patient is in this part of the limb of the curve, give fluids, only fluids. Start these drugs adjunct to that. When the patient is this part of the curve, already filled adequate volume, then comes start increasing adrenaline, vasopressin, then add adrenaline.
Okay.
This is the fluid vasopressor. Okay, again.
Dopamine, we should never use dopamine.
Dopamine is now gone almost. Okay, you use dopamine when there is only bradycardia is there. Okay, in that case we can use dopamine. Very rarely we use. Why dopamine is not used? I will write in this curve actually. Dopamine can cause. One, dopamine can cause arrhythmias.
Yes.
The dose, something called low dose dopamine was there, earlier used actually. Low dose dopamine or renal dose of dopamine. That concept is gone, never use this. In that case, what they used to do, they used to use the less than 5, 2 to 5 microgram per kg, 2 to 5 microgram per kg per minute that the dose was used, small dose to maintain the renal perfusion. They found there is increased urine output, So they started using renal dose of dopamine. They thought that kidney is improving and all not. But later they found that the dose, whatever we are using, it may be 2 mg or 5 mg. Actually, it is acting on the heart itself rather than the kidney, actually improving the cardiac output. And actually, by increasing cardiac output, by acting as inotropy, it increases the output actually. Means what? What I mean to say is, the dose whatever mentioning in the blood, it is actually in that patient it is not so. It may be you think 2 to 5 microgram, but maybe acting as a 15 microgram per kg per minute, or maybe acting as a 10 microgram per kg per minute. Means pharmacokinetic and pharmacodynamic is unpredictable in critical care patients of dopamine. So,
okay, means instead of having a good effect on the heart, it put a bad effect over the kidney
another
functions.
problem is something called, this is very interesting, it reduces the cell mediated immunity. Cell mediated immunity by acting on the prolactin. You read about this, interesting. Because you're already talking about sepsis, cell mediated immunity reducing, all theory, not practical, theory. So because of the cell mediated immunity reduction, there are chances of increasing the infection risk they are not avoiding. Actually, why you are using dopamine means, whatever the dopamine benefit I'm getting through the noradrenaline. Then why to use dopamine? And it's very potent. And whatever the benefit I'm getting through dopamine, I'm getting through the adrenaline. Why to use dopamine? So, and dopamine having risk of arrhythmias and PKPD is not very predictable. Renal dose dopamine is a myth. So, and there is risk of theoretical risk of cell-mediated immunity worsening. Then why to use it? Stop it. So, in that case, we are not using. That is where sepsis guidelines mention same thing. Got this point?
Yeah, I got it, sir.
I'm sorry. Any other doubt? Vasopressor, we can if we start talking, we can talk for 2 hours. I think time up actually. Thank you, Sumit, for presenting the case. I think he was very busy and he wanted to present. I think number is increasing now. Many people are attending the classes. They are getting interest. So I bit, but whenever you want to present, no, try to bring the case early so that we want to know what actually we can discuss. In this case, maybe Sumit want to discuss about myocarditis, and that part I'll discuss later. Basically, you should know which fluid to be given. Now it's very clear, normal saline or RL you can give, or balanced solution. How much to give fluids? In septic shock, 30 ml per kg bolus you can start over a period of 6 hours, and reassess whether a patient really requires fluids or not by looking at the PPV or IVC, collapse index, or passive leg raging test. And when the adequate volume is filled, then it's good. If it is not filled, start noradrenaline, okay, other vasopressors. That is the main message in this case. Okay, if any other questions?
No, sir. Thank you.
If there are no questions, we'll close this. Huh? Thank you. Bye.